Good afternoon. Good afternoon. Thank you. On your screen, on the left side, you see Sweden with Stockholm as its capital, and on the right side, you see that small state of Kerala, capital Trivandrum, in case you are unaware. Now, the distance between these two are 7,600 kilometers. Now, they're different. The country of Sweden and the state of Kerala are different in most ways. For example, Sweden has 400,000 square kilometers size and inhabited by 10 million people, very few. In contrast, the state of Kerala has only 40,000 square kilometers, inhabited by jostling 40 million Malayalis, right? So we are all crowded, hugely crowded. But apart from all those jokes, there's a lot of similarity between Sweden and Kerala. One is that Sweden is green, right? 75%, two-thirds of Sweden is green. 53% of Kerala is green. Okay, that's the photograph of the city of Trivandrum. There's the IT hub. It's really, truly green. But we are health professionals. Let's come to the topic of health. If you see life expectancy at birth, Sweden is 82, and Kerala is 76. That's actually the data from Trivandrum, 76. Now, the average India is 62. Infant mortality rate is 5 in Sweden and 7.9 in Trivandrum. The latest data, 7.9. Okay, right. And the all India data, 32. Right. Fertility rate per women, 1.8 in Sweden, same in Kerala. Average India is 2.6. So Kerala has a fantastic health record. But the point is different. Where Sweden wins is networking. They have a network called 1177, where wherever in the health system you get, for example, whether you are a patient, you're a physician, you're an employer, you are a payer, you are a discharge data, whatever, you go to a shop and say that I want to repair my specs, right? You immediately get into this system of network. That is fantastic. And your data is in, right? So whenever you next get in touch with the system, it clicks in that you had been there. It's fantastic. And not just that, the country of Sweden allows any citizen to get that health data. Only thing you have to show us to why you want it. I want to do this analysis, and it's open, which is fantastic. And we often joke and say the only network that works in Kerala is the WhatsApp network, right? Only the ECG from the ICU I see in my cell phone and react, right? So network poor. But then we start with two unique papers. The first one is New England Journal of Medicine that came last year from Sweden, and the other one is American Heart Journal. The Swedish paper, we all would have read that, made a huge difference in our understanding, right? One is they took about 271,000 patient data from the Swedish National Registry. And they looked at just 5 important risk factors for the diabetic. They're all diabetic, this data set. So one is A1C, B is blood pressure, C is cholesterol, the ABC that we look into. Fourth is microalbuminuria, fifth is smoking. So A, B, C plus microalbumin smoking. So they looked into the effect of these 5 risk factors onto the outcome, cardiovascular outcome of diabetes. And yes, what did they find? They found this, that if you see, for example, I am a cardiologist, so I would look at myocardial infarction, MIs. If you take control OKs, everything is on that straight line, right? Everything is on the straight line. Now, if you have all the 5 risk factors, A, B, C, A1C, blood pressure, cholesterol, microalbumin, smoking, corrected under control, you see still those blobs are on that line, meaning that the risk does not increase at all. And that's why, in summary, the paper said, in conclusion, type 2 diabetics who have these 5 risk factor variables within the target range appears to have little or no excess risk of death, MI, and stroke. So for prevention, if you control A, B, C, microalbumin, smoking, you are safe. Your patient will not have a cardiac problem, right? No death, no MI, no increase in death, MI, and stroke. They will die, of course. Anybody has to die. But then, as a cardiologist, we are looking at something else in the same data set, and that is heart failure. Look at heart failure. Even if you have all those risk factors under control, all those A, B, C, microalbumin, smoking, and if you have a gentleman who is 55 years old, his lifetime risk of developing heart failure simply because he is a diabetic is what? 2.4. So controlling risk factors, sugars, A, B, C, microalbumin, smoking, does not help in preventing heart failure progression. And that is a very important data set before we go into the topic. The other paper is, we always show it with pride and prestige because this is called the Trivandrum Heart Failure Registry. It comes from the capital of Kerala. It's a small data set, 1,200 patients. But today, whenever we travel abroad, we present our papers, Trivandrum Heart Failure Registry, because it came in the European Journal of Heart Failure. That's a 90-day outcome. And we were surprised when the one-year mortality data of the same subset we followed up came in the American Heart Journal. But the data is very disturbing. It says we found that there's a 10% in hospital mortality. One-year mortality is, 30%. 3-year mortality is 45%. And not just that, even in that so-called educated state in Kerala, only 19% patients come in with a guideline-directed medical therapy for heart failure. See, this study was done only from 13 urban hospitals and 5 rural hospitals in the district of Trivandrum. Okay, and everything was supervised by the cardiologist. And still only 20% patients give the standard things like beta blocker, RAS inhibitor, mineralocorticoid antagonist, and whatnot. So, our treatment is poor because probably we are not in the network. And that brings us to the topic that is given to me today is 2 things. One, glycemic control and cardiovascular events. Are they related? And if so, how strongly? And the second thing is the combination of SGLT2, so many people ask, and DPP-4 inhibitors do their work, especially from the cardiologist's purview. We always say that, cardiologists take an oblique view of everything. Even if when we see the X-ray, we see like this, right? When we do an angiogram, we say right anterior oblique, left anterior oblique. Cardiologist's view is always oblique. Anyway, so the point is, if you look at the data that came in Lancet 2010, a huge data set, you can see that is 698,000 patient data. And look at in the diabetic, the coronary heart disease data. We see that diabetes increases coronary death and non-fatal MI to the tune of 2.3 and 1.8, significantly. So let us take the coronary death of 2.3, right? So we are trying to establish how far is the risk factors important in the genesis, right? So let us take and adjust one by one. If we take the data of 2.3 and adjust it for age and sex, it comes down to 2.06. We adjust it for smoking, it is 2.1. Adjust it for BMI, blood pressure, it comes to 1.9. Everything, cholesterol, HDL, TG, it comes to what? 1.87. So despite all the adjustments, blood sugar still plays a very important role in the cardiovascular event generation, right? That's very clear. But in the same data set, if you look at the graphs, for example, this is systolic blood pressure. And, on the y-axis, you have the hazard ratio of vascular events. You see the line is straight and very strongly correlating. Let's take total and non-HDL cholesterol. The line is straight, very strongly related, right? Linear. But if you take blood sugar in a diabetic, the line shows a J pattern and the relationship is weak and feeble. So yeah, we need to control blood sugar. That has got a benefit, but we have to also take care of other risk factors as shown by the Swedish registry. We know that hyperglycemia tend to affect liver, the endothelial cell, the kidneys, and they increase atherosclerosis, accelerated atherosclerosis. And we are also aware that is what was looked into all the intensive glucose control studies. You are diabetologists, you know that. The VADT, the watercord, this thing, all those trials, including UKPDS, you looked at intensive glucose control. And what did you find? What do you find in that UKPDS, Accord, Advanced, VADT, everything together? If you see whatever meta-analysis is published, everything shows that yes, glucose control, intensive control, does reduce MIs, cardiac events to some extent, yeah, certainly. 10, 15, 17%, yes, it does reduce, right? But in contrast, when you look at the CVOT data, we have 13 CVOT data available today, and this data is non-fatal MI. In the CVOT trials, we see non-fatal, everything is straight. You've seen that slide, right? So which means that CVOT trials have shown that all of them are safe. All of them are safe. And for example, if we look at the CV death, same pattern, but we see that Emparage showed that empagliflozin stands way. So it is distinctly beneficial. Sometimes we say that empagliflozin is a cardiac drug. For example, now DAPA heart failure has shown that it's beneficial even in the absence of diabetes. So EMPA is a heart failure drug, or a good drug for the cardiologist, only thing it has come through the CVOT trial. But the point is not that. When we try to look into or extrapolate the data of these two, IGCT is the intensive glucose lowering trials. Look at that. The intensive glucose lowering trials, your VADT, Accord, and all those trials together, they reduced HbA1c by 0.9%, right? Delta is 0.9. And that gave us, returned a hazard ratio reduction of 0.91, meaning that 9%. So 0.9% reduction gave us a MACE reduction of 9%. But in the CVOT trial, the new drugs, okay, everything together, we have not taken only SGLTs. We have taken the DPP-4, SGLTs, everything, including the DEVOTE, every trial. We see that much less HbA1c reduction, 0.42%, reduced MACE by 8%. Okay, so much less is HbA1c reduction by the newer drugs give us almost equivalent benefit of intensive glucose lowering, right? So if you put that data in a graphic form and have in the y-axis the hazard ratio of MACE and the x-axis HbA1c reduction, you see there's a fairly straight line, right? And if you calculate that regression value of that, and transpolate that regression onto the CVOT trials, and say what would have happened if I reduced with the CVOT new drugs and HbA1c to 0.90 like the intensive trials, you would have got a 33%. See, I'm a statistics person. I've written a book on statistics. So there's a 33% reduction of cardiovascular events if your new drugs had produced an A1C reduction equivalent to the intensive trials. So we said that for the same A1C reduction, this is important, new drugs are better in reducing cardiovascular events. Now, look at one more interesting caveat, and that is if you squeeze out from the intensive glucose lowering trials those with CVD, you see there's a hazard ratio of 1, right? But if you take out, for example, SGLT trials and take those out with an CVD, you get a hazard ratio of 0.86, 14% reduction. So it tells us, in addition to what we had already said, yes, new drugs are better, we say that more so in the presence of cardiovascular disease. So if there is somebody who presents with a cardiovascular disease and not just multiple risk factors, probably our choice would be to go for the new drugs, which has been shown to be effective in the CVOTs. The last two slides where we would remind ourselves, we know that food from the intestine stimulates production of GLP, and GLP obviously increases insulin, decreases glucagon. We are familiar with this slide. And the only problem is GLP has a short half-life because it is destroyed by DPP-4 enzyme. If you are not aware, I heard that God is creating a new human being version 5 with a long half-life of GLP and no DPP-4, and then probably we don't need to have a meeting like this. But till then, we have to understand that apart from DPP-4 inhibitors, the other one that we have is SGLT inhibitors, right? And we know the mechanism of action, but the point is SGLT2 inhibitors decrease insulin and they increase glucagon. So they act kind of opposite to the DPP-4 inhibitors in quantum of insulin and glucagon. So if that is so, the question comes in, why don't combine both? And the data is very strong. For example, the left set is without metformin and the right set is metformin. The graphs are EMPA, LENA, and combination. Look at that. When you combine, for example, this is LENA 5 and EMPA 10, and the second graph is LENA 5 and EMPA 25, you see HbA1c reduction is significantly more. And as we have shown in the new drugs, if you had reduced HbA1c more, you would have certainly benefited by reducing cardiovascular events, as is shown by our meta-regression curve. With metformin, without metformin, both same. We do benefit if we combine LENA and EMPA. So like somebody said, that somebody has come with an diabetes and has cardiovascular disease. Would you avoid metformin? Yeah, why not? Because even with that, your cardiovascular benefit remains same. Not to forget that metformin is cheap, universally available, and that's a different story. Same thing with DAPA and SAXA. You see the combination of 10 DAPA and 5 SAXA reduce A1C far more than any of the drugs alone. But as a cardiologist, we are more bothered about not A1C reduction, which is your field. We would look into the blood pressure reduction, which is good with the combination of LENA and EMPA, good in the presence of metformin, and in the absence of metformin, they've shown to be good, as good and even better compared to the individual drugs alone. Now, this is something that had just been mentioned by the speaker before me, that, if we look into the risk of hypoglycemia with this combination, see that it is almost 0-0. 0 means that it probably is not picked up. But the point is that these drugs, the combination of LINA and EMPA, has not produced any significant hypoglycemia, which is certainly a point in favor of this combination, especially a patient who is a cardiac patient. And we know that cardiac patients, when they get a hypoglycemia, they might get arrhythmia, cardiac arrest, and so many other major events. This is also interesting that when we looked at genital infections and we looked at the EMPA data, 4.4 and on metformin is 8.5, and when this combination group came in, it was 2.9 and 5.9. I don't really believe that the addition of LINA actually reduced genital infections, but probably it just tells me that it has not increased, right? It has not increased. There is no mechanism to explain why they should have lesser amount of genital infections. So the take-home message at the end of all this is, one, glucose control does reduce cardiovascular events. And more quantum of glucose control, better the cardiovascular outcome. Very, very clearly shown. Control of other risk factors, apart from sugar, those A for A1C, B for blood pressure, C for LDL cholesterol, and of course microalbumin and smoking is very clearly shown to reduce cardiovascular disease, except heart failure hospitalization. No effect of heart failure hospitalization despite control of sugar and all these other associated risk factors. And as we have shown, heart failure is a real big problem in India because we have a very high mortality rate in hospital, 1 year and 3 years, and very few of our patients actually receive guideline-directed medical therapy for heart failure. SGLT2 and DPP4s tend to individually improve cardiovascular events. If you are unaware, SGLT2s today have a huge amount of real-world data, which shows that yes, they are beneficial. SGLT and DPP4 are complementary in action. Okay, one increases insulin and reduces glucagon, the other just counteracts it. And obviously we have seen in clinical trials that the combination certainly works well. So glucose control with the new drugs, I believe that this combination looks extremely promising from the cardiologist perspective of view, both in lowering of blood pressure as well as lowering of cardiovascular events. So don't just take home a knowledge, right? So the point is always use them. Unless you do that, it is pointless. Thank you for your time and attention.
Thank you, Dr. Nair. Can we move on to the panel discussion? Dr. Bhattacharya and Dr. Chandale, if you want to join us here.